Good evening and welcome to the meeting of the Adult Social Care and Public Health Select Committee. I am Councillor Sarah Addenbrooke, the Select Committee Chair. This meeting is also being streamed live on YouTube, and members of the public and media are welcome to watch the meeting remotely and listen to the discussions taking place. I would like to welcome all those here, especially our newly elected councillors and everyone watching on YouTube. As in all our meetings, it would be appropriate for us all to start with a 72-second silence to remember those who lost their lives in the Grenfell tragedy. Thank you. As this is our first meeting and we have a number of new councillors, I'm going to ask everybody to go around and introduce themselves, including the officers, if that's okay.
I am Misuse. I'm councillor for Holland, and I'm vice chair alongside councillor.
Hi, I'm Robert Blees and I'm the Chief Nursing Officer for Chelsea Westminster Hospital.
Hello, I'm Dominic Conlon. I'm the Hospital Director at Chelsea Westminster.
Stuart Brown, Councillor for Law Board.
Sam McAvoy, Queensgate.
Christian Bagans, Health Officer for West London.
Good evening everyone, Bernie Flatty, Executive Director of Adult Social Care and Public Health here in Kensington and in Westminster.
Good evening everyone, I'm Anne Siren, I'm the lead member for Adult Social Care and Public Health at Kensington and Chelsea.
Evening, I'm Rachel Soney, Director of Health Partnerships for Kensington, Chelsea, Westminster, Adult Social Care and Public Health.
Hello, I'm Anna Raleigh, I'm Director of Public Health for both Westminster and Kensington and Chelsea.
Good evening, I'm Gareth Hall, the Director for Integrated Commissioner.
My name is James Diamond. I'm a Scrutiny Policy Officer supporting the Select Committee.
I'm Yasmin John, Governance Officer for the Select Committee.
Thank you, everybody. So moving on, A1, note the membership of the committee agreed at the 25th May Council meeting. A2, apologies for absence. We've received apologies from Councillor Hargreaves and Councillor Ahmed. Declarations of interest. I confirm that I have no declarations of interest to make regarding any items on the agenda. Do any members have any declarations? On to minutes of the meeting held on the 3rd of March and the special minutes from the 25th of May. Does anybody have any comments? I don't think many of you were here. So we move to A5, the Quality Accounts for Chelsea and Westminster Hospital NHS Class 21 to 22. This is the main item on our agenda tonight. And it's an important document which sets out the hospital's priorities for improving care quality and standards. So I'd like to welcome Dominic and Robert. And perhaps you'd like to share an introduction.
Thank you very much, Chair, and thank you very much for inviting us to this. It's great to see, 2 years or so since the meeting has come together again. And some friendly faces office here. If anything has changed as well, I can tell it's I've actually inherited some glasses doing too many meetings on Teams, so I'm really grateful back face to face. And also there's an apology. In the many formatting versions of this you've had around here, actually priority 4, improving the end of life care, the editing fell off the there. So I've brought up the one page, something to the text that wasn't included. So apologies very much for taking a page and passing around. Point that out. Which things are actually asking to comment on quality improvement, which is important detail about what it means, why we've chosen it, and how we're going to measure it. This is included in that, so apologies for that. I don't want to spend very long on an introduction. I think it's much more important to have the dialogue and that we get your comments and identify the themes, both about this report and going forward about a quality dialogue. The quality account is a statutory requirement. We have pretty limited ability to play around with the format. It's a pretty dry read, so I'm sorry about that. We've tried to put a little bit of local colour into that in the sense of the Chief Executive's forward, with the review of pictures, sense of some of the areas, but otherwise it's pretty prescribed. So apologies for that. As our host screening committee, we are obliged to, and we want to get your comments on the record, and that forms part of the submission that we make back to central government as they before Parliament. So that's the formality of why we send it to you while we're here. For complete transparency, we also share with Local Health Watch, we also share it with our colleague, your colleague at Human Screening Committee at Hounslow, which is the host for our other site, West Middlesex, and we'll include their comments as well. And our statutory host, yours is the one who come talk to tonight. Essentially, the key aspects of the priorities that we achieved last year, what we hope to achieve next year. And then just to give you a bit of extra colour in terms of wider assurance around that. It's not in the report, but just to remind everyone, so in the sense it's important not to just take our word for it. The trust has been, not formally, but it's had the CQC on site in the last couple of years. We've retained our rating of good. The Chelsea site has retained its rating of outstanding. The Health and Safety Executive undertook a formal assessment in December 2021. The trust was rated in the top tier of workplace providers. We had no material breaches or immediate actions, which is just very heartening. You know the rest about our scale. We're busy, one of the top 5 business units for emergencies and top 5 in terms of scale for maternity. And we were particularly proud of the new intensive care and neonatal intensive care units that we opened this year. We hope that by innovative use of the estate and taking advantage of lovely buildings, we will actually take that to the sort of environmental and experiential impact for our patients. So it's not just a clinical and technical care that we provide, but it actually feels like great care, it feels like the right environment to provide care. And then finally, we are in the top quartile of NHS providers of key metrics for our staff survey, which again I think says a little bit about what they think the quality of the service we provide rather than what was. Chair, I know you identified 3 things which I know we want to talk about, but I suspect you want to ask other colleagues if they've got any particular comments on the report or how we've got to take it forward.
Do you want to? No, I'm sort of reading the report, you want to focus a lot on how you're communicating with your patients. And it's not necessarily coming at all from your trust, but hearing from other experiences of other trusts around London and how people are facing it when their letters about their appointments are turning up, say 2 or 3 weeks after the appointment actually was. And I know that the NHS app is amazing and I use it all the time, but I've noticed that if you're not necessarily digitally savvy and you're of an elder generation, whether they are checking those apps and how Chelsea and Westminster are communicating and sending their appointments and making sure that people are hearing about communicating in hospital so that people appointments aren't missed. Can I just add to that, digitally excluded is obviously something we all talk about. And obviously, patients that who English is not their first language comes into that whole.
So in terms of timely communication, you'd like to call out the great work that the NHS has done through COVID, but it's not the sole method of communication. We still, as you'll see from the quality priorities, focusing much more on timely communication from a letter perspective, and that's twofold. One, in terms of good old postal service back to our patients, but also communication with the GP and making sure that it's timely to continue their care. We know that patients will pick up the phone and ask their GP, have they got the letter, what's the plan, and also communicate back with the organisation. And then also in that digital space, much more as we move to more digital innovation, how do we encourage patient-initiated follow-up? And that's a real opportunity there for patients shaping their care, having a direct dialogue with their clinicians, but absolutely there is a health warning there, making sure how do we make sure that is really inclusive. And I think we're early on in that journey in terms of including our patient partners as part of that co-design.
Yeah, I suppose you summarise it all really, but I guess there's two themes for me. There's the bit that's directly in our control, such as the letters and the sort of way in which we digitally communicate. And there's the bit that actually isn't us communicating out and you get what you get. It's actually listening and sort of trying to sort of say, well, okay, either how can we improve that, or what are the patient-reported experiential measures that we can start to sort of develop so that we can actually be a bit more responsive. I think you probably say this quite a few times, but for the last 2 years, it's been quite a didactic sort of process, a quite a didactic system, and I think we've kind of a bit of a risk of losing some of the connections we have with our local population, and so I think that's really important, and that's one of the reasons why communication at large is here in the quality accounts. We see it in the ED department every day when we know that some of those patients that need to be in the ED department, but they want a face-to-face consultation.
Yeah, just ask you, could you explain ED department?
Sorry,
Some people don't know what it's short for.
The emergency department or the accident and emergency department. And we can say what we like about what's an inappropriate attendance, but they're telling us something by their attendance. And so the communication, I think, is partly to say what we can measure, what's in our control, and what we can develop.
And then in terms of how do we co-design with our patients, we, like I said, early on in that journey, already in terms of your point around English not as a first language, a lot of our patient information leaflets we have already got in multiple language accessible, admitted on our website and through QR codes in the department. But I think it is actually, there's one thing translating it verbatim, but actually what does that mean for that individual person and also that society? We have a new head of patient experience, and we've invested in a 12-month person head of patient engagement that started 2 months ago when I started, and that's one of the key pieces of work in terms of, okay, how do those two roles work together to improve that wider patient experience within the organisation, but also with external communities as well.
Thank you. Thanks for coming this evening. I just wanted to, I've got a couple of questions specifically on handover. Firstly, obviously we know that handover is quite important. You don't want to be missing the thing in your patient journey, which can cause problems further down the line. I just wanted to sort of specifically around, you mentioned the Cerner system, the ER system. What is the reason for that not being 100% utilised? You mentioned utilisation being probably not where you would ideally like it to be. What's the reason for that?
So I would say it's not that the Cerner system is only used, so it's just a specific tool of handover.
Okay.
Yeah, so there's one element. That, however, there are little pockets where people have used bespoke systems sometimes in the maternity department, particularly imaginary type. So there are some areas, and we're still working to try and make Cerner the sort of foundation stone. But many of the systems and processes the teams use have either for national comparator metrics or international systems, or simply because actually the Cerner system, Millennium, it was designed in 2000, and actually some systems have sort of we've added to them. So the 70% relates specifically to the handover element. But nevertheless, it does give you an indicator that there's an area, quite a big area of the trust where if handover is happening, it's not necessarily captured in a sustainable way, or it's not necessarily sort of gives us the assurance that we would want, given we talk about communication. So it's as much about making sure that we are absolutely assured that safety system is in place. So that's a very broad.
I think to add to that, how do we get from the 70% upwards? I can say this because I've come from another organisation. I've been in the organisation 12 weeks, and actually we've implemented Cerner as a trust, and now it's how do we optimise that and make it more usable for our end users, so our clinicians and our nursing staff. And actually, there are some core principles of handover, but actually what are those additional elements that are specific to those specialties, and how can we tailor Cerner now to make it user for them? And that's not just on handover, but actually that's the whole of the patient journey in terms of the health record and how we optimise that and make it more meaningful for our nurses and our doctors, that it helps them rather than hinders them. And we're in that space now over the next year about our digital innovation piece around Cerner.
Can I give you one other example of that? So when we had the health safety executive that said, and they looked at the work we did on the risk assessments that I thought were relevant, and they commented that actually, and I think our staff were telling us this, it feels more like a process for getting risk to the system rather than for actually managing the risk. So to Robert's point, we want to make this checklist something that actually is clinically meaningful, and that sort of kind of captures the key things, and is the sort of thing that a clinician will talk about to another clinician. So that's one. And then very specifically in the report, we are finding increasing numbers of patients being admitted late in the evening, and increasing numbers of patients being discharged late at night. So the whole sort of 24-hour clock is becoming much more pressure for us. So that's why we particularly call that hospital at night meetings, to make sure that that element has become, we don't have any sort of safety issues to that. So it was a bit of it felt like a hole in the system, but it has to be plugged in a way that Robert said that is clinically meaningful and is not just a way of getting the data into the system.
And that 30% that's sort of not utilised in the handover process, what is the process for that? People miss utilisation of that system. How do they do it? Is it manual records? Or?
So it's a combination of either manual or verbal records, which are translated to, much of which is centred in that nighttime focus. And then there are 2 or 3 outlined departments for whom we'll go down to very specific retraining and looking at the way the system is being used.
And then what do you assess as the reason for that 30% figure of underutilisation of the system during handover? Is it staffing, just the
it's a resource system, it's training of staff when they come in. So you could have an organisation X that operates an Excel system and a paper handover, and now we're asking you to do something digitally in IT. So there's an educational training piece. There's an element in terms of, as Don was saying, only half of the handover element is captured. It's relevant for that speciality. So actually, how do we now build that within the IT system so you're using the full element of the handover? So rather than saying, actually, I'm not going to use the first part because it's duplications and having to do something separate, it's actually make up one of the other 2 main pieces.
I'll be very honest, I think certainly at night, you've got the medical registrar, the surgical registrar, are the 2 senior clinicians on the site outside of the emergency department, and then directions to try and make this as easy as possible for them, to make sure that they are delegating that down and it's captured properly. And I think that's the pressure. I've talked about more patients being admitted at night, more discharge at night. We will genuinely look at our kind of staffing works, I think, to try and reflect that pattern.
I was going to add something on that, so you
more broadly in terms of the application of technology to the patient journey, I think speeds it with this digitalisation that you were mentioning. Obviously, I think I visited a couple of years ago with the Secretary of State during, I think, sort of middle of 2019, late 2019. It was clear then that you were doing a lot of work on how to improve that patient journey through technology. One thing I wanted to sort of ask is, are there other systems that you could perhaps be using in the future that would improve that? Have you got more things on your radar?
Yeah, we're a national pioneer for a Palantir boundary, which is basically use of a scheduling system, use of algorithms, but it actually turned itself into not just that, but more than sort of clinical decision support system. So that you kind of take the information. A lot of our staff spend a lot of their time putting in information into a system and actually getting very little out of it. So we want to try and get something that makes, supports them either through dashboards or predictive modelling that allows them to start to say, well, actually, how is this going to help me manage my workflow? So we're doing some work nationally leading that, starting with theatre scheduling, theatre and animation scheduling, but it can cascade out to a whole series of other areas. We did some work with a number of other companies through CW Plus, CW Innovation, we've had a number of events where we've tried to use that predictive modelling process that starts to say, if the clinicians can identify the key factors, we can try and build a model that sort of pulls all that together and presents it back to them in a way that's meaningful. They can make better decisions, quicker decisions on that basis. And ultimately, that's the key. We don't really, that's what digital maturity means. Not you're very good at counting it, but how do you use it and actually improve the care?
Yeah, I think right. So the technology is wonderful, but if it doesn't produce any meaningful results at the end of it, it's pointless and waste of money. So correct. Thank you.
Yeah, well, that's part of my question is that does it link up with the GP surgeries? Because obviously if you're discharging people coming into hospital, you can look at their records. It would probably help you. And do you think you're getting more people arriving at night because they haven't been able to get a GP?
So question one is, technically it is possible for this to connect into system one and the wider GP systems. Previously, Cerner and all of the systems, technically it was possible to link into all that. We need another, in a way, this is where the integrated care partnerships we were talking about and the integrated care system we were talking about has to help us all decide that the prize of common view of the patient and to help the management in it is worth our own individual bit of turf on that. We just have to come to that consensus. Otherwise, we can put the best systems in the world, but if we don't choose to share data meaningfully, well,
I would say that the patient discharge summaries are electronically transferred to individual GP surgeries, so there is already an interface there, but in terms of the full health record, no, we're limited on what's on the summary care record and those medication history, vaccination history. We do share a platform with Imperial, so we do share that. We can view the health records of our patients that are accessing care at Imperial, and as we move forward, we provide a collaborative, and we all use the same system. Cerner, the vision is that across the acutes, we will be able to use the health record technology and our patients move between the different hospitals. So there is a direction of travel there, which is the GP.
Yeah, the second question is I don't know. So there's some audit, some patient-reported experience they're finding difficulty accessing appointments. I suspect actually many aren't trying. They may have heard that other people are having difficulty accessing it, or the choice between spending a number of hours in an emergency department may seem more attractive than a number of days waiting to see someone, and that's always been a bit of a trade-off that the system has had, but it might feel more acute at the moment. For whatever reason, we've looked at some of it, and some of it I think is our own processes around that we've seen. It's taken. We have one of the things we've looked at is it's clear that some of those patients that we had quickly turned around and were able to sort of support and go home, that seems to be taking longer. So our average time in the emergency department is growing. So some of that is that's pretty common across the NHS. There are a number of sort of checks that everyone's obliged to do now, so in some senses things are built into that, but that's happening. That actually, if you look at the time of attendance, it seems to be getting later in the day. Whether it's to do with moving on the GP system or not, I don't know. But a real urban feature is it's
Anybody else have a question?
Health Watch are setting the response to
James and Secretary to the committee. Just, it's very good to see the emphasis on communication with patients being a priority. Looking at your case, the response rate is low. Would you be able to give us any indication about the number of actually relate to communication? I mean, you say we're going to improve on that. Is it actually a predominant theme among patients at the moment?
So I can try and find because we've just done an annual complaints report that we're going to report this month. So I can definitely get the numbers and let you know. I think it's fair to say communication is one of the themes. That's quite a broad thing. So communication, treatment decisions, are some of those top things. In terms of our response times, you're right, our response times did take a dip. Certainly over the last 2.5 months that I've been in the organisation, what I can say is our response time is back up to 95% of our complaints being responded to, and we've got additional processes in place to make sure that we continue to respond to 95% of complaints within the stipulated time scale, because if someone's concerned enough to write a complaint, they want a timely resolution, and that for us is really important that we give them that response. So we have got additional steps in to maintain that. In terms of the themes of communication, it is broad, and I can come back to you personally some additional things, but it will be around my outpatient appointment. When was my outpatient appointment? When was my theatre appointment? Or actually, real sex didn't explain this to me well enough, or I didn't understand, so can you give me some follow-up information? So what we're doing with those broad communication themes, as it were, the highest number relate to discharge information, and outpatient appointment time. So that comes back to that timely communication with our quality priorities. So quite often, patients are told that they need to follow up, but we're not always timely communicating that. So we're often writing to the number of times saying, when is my follow-up appointment? My clinician has said I'm going to be seen outpatient in 8 weeks, so I haven't got an appointment.
I mean, that was just a really important point made. The treatment, the treatment of vulnerable communication.
Thank you both for bringing it. Considering what we've all been through for the last 2.5 years, I mean, I think it's pretty impressive.
So yeah, thank you very much.
Can you believe we could all come and see you sometime?
Well, please, I was going to make one offer. So some of you will remember that we actually organised one of your meetings in the hospital, and we got our staff to present to you in terms of progress on quality priorities, and we'd like to do that again. I think it's kind of engaging in terms of way of advising you, but also I think it provides a level of assurance to you as external scrutiny and holding us to account that if our staff are buying into this and are presenting it, actually kind of meaningful. And it's a really good experience for them. They really liked doing it. They were very nervous about it, but they really liked doing it.
No, it was a really good meeting, actually.
Yeah, so we'd like to do that again.
I mean, we appreciate that we don't know what's going to happen in the next few months.
No, but as we can hold to the principle, hopefully, trying to do that. And then the second comment, I suppose, is there's been another conversation. I probably shouldn't say that, get out of my head, shouldn't I? But by definition, these are quite health-oriented goals. Spend a bit of time talking about the integrated care system, and over time, I think we'll see the quality count and quality priorities develop that. So as the health and wellbeing strategy is developed locally, I think we'll start to see, potentially one of those starting to take a grip here, and it already begins to happen. So we part of the reason we chose the ones we chose is because sometimes we're an outlier, or sometimes we think we have a really big impact on the population. So falls, we know really extends length of stay. As a trust, particularly in this side, we're a bit of an outlier. The end of life issue, actually part of the answer will be the way in which we manage this through our joint discharge hub. Once we identify those fast-track patients and support them to be at home, it's our colleagues providing packages of care, support to the community, who will actually support those patients. So I think it will come. and we're really conscious of our part in the ICS and the part that others can provide to provide a range of support. So it is very helpful. It will change. Help us to do that by setting out a really compelling health and wellbeing strategy.
Questions, the ICS.
Yeah, the ICS integrated care
How long
system.
have we got?
Broadly, the integrated care system is the North West London overarching structure. Yes, we all play a part locally. So our main relationships are with my borough, with your borough, Kensington, Chelsea, and with Westminster, and there's a local forum that does that, which is effectively a bit of a building block. So there are still very much the local relationships in place. I tend to think of the ICS as a way of working rather than a thing. It's simply to encourage us to think about the care we provide outside of our four walls, not just inside hospital. Our main partners are Community London Central Healthcare, Community Trust, the Borough Teams, and CNW Mental Health Trust, and the range of voluntary sector providers, the third sector providers who provide some amazing stuff. They're our main partners. Probably fair to hear that also Wandsworth is a fairly big user of the system. It's actually the largest single borough in terms of the maternity deliveries at the site. Slightly younger population, and that part of North Wandsworth over the river, all the developments growing up, that's a very young area. That's so children's services, maternity services. So we've got some very specific relationships with Wandsworth, but in the main, our partners are, as I mentioned, and those that effectively come to your table and give you an account of their performance. Thank you very much. So we have your comments, which there, and I don't know if there's anything else you want to add in after this meeting, please, if you do, just let us know afterwards and send it in, and we'll make sure that the full comments get appended to them. Thank you very much for your time.
I really just had a couple of comments, which is, as you've said, Chair, I think performance is really good given everything that's been going on. I was actually particularly interested to see the outstanding ranking in sexual health performance. And I just wondered if you have any comments about how you've managed to achieve that.
I mean, the Trust has a long history of provision of sexual health services, so one of the pioneers of the original HIV treatment. And it's one of those great things, when you have a really great unit, it almost attracts great people. And so success breeds success. And I think that's a lesson we've really thought about encouraging them, providing a level of what we call earned autonomy to some of those departments. So they've probably got a bit more leeway and take a bit more risk in some of their developments because of their track record. But they have some amazing clinicians and some amazing other staff who want to support that team. And it's built up, and we provide services across London, across the south east. I think we provide 70% of GP services due to London as a trust. It's mostly the people, their commitment, their skill, the combination of that is just irresistible force, etc.
I would certainly echo that. So being a community organisation, working with them specifically around recently monkeypox, they have been innovative and leading and responding to that across London and sharing their practice. And it is the senior clinicians that are very strong advocates for their patients and experts in their field that are using us, as it were, to sample their ideas and test them out. But empowering them to do that, it's really been great to see.
One of the examples when the work the clinicians did there. So we've had this Lily system in place, which has allowed us to support the Dean Street and have report results. So when people attend to the sexual health clinics, have their path results, and we use this pathology and reporting system to get their results next within 4 hours. We use the same technology to sort of build a platform to do our staff testing for COVID. But it was the sexual health clinicians who led that, using using the sort of assimilation. A number of the care homes started to use that with what was in the national portal. It's converted across that now, but it's that kind of innovation and that kind of can-do culture that's really. And part of what we do is to try and support that as far as you can, and then if you can't, just be honest and clear as to why not. And then what's the next idea?
Very good. Thank you. It's really interesting.
Yeah, we're really proud of that team. Thank you very much, guys. That's a good note. Thank you for that question. It's a good note to leave on.
So we move on to the responsible report from mental health.
North Kensington Working Group. So there were a number of recommendations
In that report, which
we're working on some
of them
on Appendix 1. The CWL response was slightly woolly. I think we'd like some evidence of what they're doing in the voluntary sector. Push it out.
Yeah, Chair, thank you. E6 200 appendix. I'd like to know what are the findings on the local health service and the provisions for the community. Is there any limited report on that?
Sorry, on recommendation 3.
Yes, for appendix 1 and 2. So they'll be looking at findings on the local mental health services and provisions for the community.
These papers aren't numbered. Oh, sorry, 3.3, I'm covering them.
Yeah.
So that was part of the process of the working group. And we came up with various recommendations. So if you go through to Appendix 1, it's got what the recommendations are that came out.
Yeah.
And we've had some responses, but I don't think if you look at recommendation 3, again, I think we need some reassurance that the commission will be more coordinated going forward.
I think the link between the voluntary sector and the NHS needs to be established for us to have to measure how patients are doing services.
So there is a working group. There is a group that meet, which are the NHS Commissioners, some from the voluntary sector, I understand, and the local authority.
Yeah, so for the North Kensington Health and Wellbeing Commission Services, as part of the Grenfell Recovery Programme in particular, there's a group called Together for Grenfell, which we commission as a local authority, which includes a number of voluntary sector organisations, some of which have been funded for several years, some of which are newly funded to provide peer support. And we convene and provide a forum of those organisations that comes together. It has been bi-monthly, it's now moving to quarterly, so every 3 months, to discuss the progress of their work, how they can help each other. But crucially, it's not just us and the voluntary sector, we also invite CNWLs and Mental Health Trust to come and talk about their commissioning work too. So the point is being made here in this report about making sure there is a coordinated and joined up way of working between us as partners has a kind of foundation in place for it and has been working on that basis. But I think responding to the recommendation and challenge in the report is, well, okay, when we look for the next phases of what the commissioning looks like, as some of those services change over time. Some of them become mainstream commissioned by the Mental Health Trust or potentially by us. Then we do that jointly with the voluntary sector as well as between us.
Thank you. I just wanted to know how we're measuring our service processes and how we help the local residents. I mean, those systems, they seem well close to me, but I just wanted to know if we can value for service and money.
Yes.
I mean, each of those services that are commissioned, particularly within the Together for Grenfell consortium, have contracts in place with a set of measures associated with them. I'd be happy to share the latest iteration of those with the committee so that you can see how they're tracked and how decisions were made at the last round of recommissioning those services about continuing with ones that already exist, albeit changing them a bit, and then expanding some of that investment so that, as I said, there are now some peer support groups in place to share that force information.
Thank you.
Does anybody else have any other comments? I mean, I think we've just got to keep monitoring some of this.
I'd like to contribute. So my comment is really about working with the NHS, and I think Councillor Baxter is absolutely right to talk about monitoring and what we're achieving in terms of value for money. But actually, for me, the real value is working with our NHS partners. And I have to say, with my previous hat on, my previous experience working with some of these commissioned services, I don't always feel that it's completely joined up with the NHS, or that there's transparency or visibility of what they're doing. So I mean, my recommendation is that we find ways of getting to the NHS representatives that are in charge from their side, and getting this a little bit more joined up, and particularly thinking, as we now progress out of the Grenfell recovery strategy to whatever's coming in the future, we really have to work together closely. And I think that personally for me has been lacking.
Yeah, I think it's very difficult because they're commissioning things, we're commissioning things, sometimes we're commissioning the same thing. And it hasn't been joined up, but I think it's really important.
I don't know how we do it, because I think we've tried to do that, and I'm not sure we've, not through want of trying, but I don't think we've really succeeded. And certainly what I saw was exactly what you've described. Because you'd go out and you'd sort of find things that they were doing that we were trying to do, and it's a shame really, because I think together it can only be better. So I don't know if anyone's got any ideas about how to achieve that, but I think that's what we should really be focusing on.
Yeah, thank you, Chair. So certainly the ambition is absolutely right, and I think Christine and other people would say that is, we quite often get that from residents in terms of that reflection as well. I think the ambition, Dominic spoke about, I'm sure we don't want to talk too much about it, but the ambition of the ICS and the other acronyms involved, the ICP, the ICB, and the place-based partnerships, is that certainly in both boroughs, we have identified that mental health is absolutely something that all the partners want to really do exactly in the way that Anne's described. Just managing expectations, it's quite early days. So we are establishing this is important. We are doing a piece of work, and Rachel's helping with scoping what are the things that we're actually all commissioning, what are the support mechanisms mixed with, and David Bellow is leading on the piece of work from the council in terms of mental health. So that is the ambition. We probably have, obviously governance, but we have things in place that will help get to that. But I don't think it will be a swift process. I think it might, so we may need to do something parallel to make sure that we're kind of a bit more joined up, and maybe it's certain areas, certain elements of mental health that we kind of start on and make sure we're tight on that as we're building other systems for a much more kind of holistic approach to supporting our residents with mental health.
Anything else? Any other comments? I think we're just going to have to keep monitoring. I mean, this is particularly on North Kensington, but obviously we've got a big interest in this committee about mental health, and I know you're working on strategies, so we'll talk about that later. So we can move to A7. This report provides the key information and priorities for adult social care and public health, particularly in the year ahead. I'd like to invite Councillor Sarah and Bernie to speak on this.
Well, thank you, Chair, and I'll start if I may, Annie. So actually, I found this a really useful paper, just setting out exactly what the directorate does. And for me, you know, being new to this portfolio, it was a really useful introduction and summary of everything that we are responsible for, adult social care and public health. And it, you know, the first thing you notice, it's a massive portfolio, and it's a really important portfolio. And it particularly provides support to our residents when they're really in need. So I think this is a massive responsibility, and there's lots to do over the coming year. So certainly up for the challenge. We all know that this is a by-borough arrangement that we have with Westminster, but there are also specific initiatives that are focused on our residents. For example, the community health worker pilot. The other thing that I found interesting and would probably urge everybody on this committee to, you know, really thoroughly sort of understand is the legislative frameworks and the budget that the directorate works within. And particularly section 3 of the report, which talks about some of the upcoming social care reforms, which we're going to be facing. And, you know, that's going to have lots of implications for us, particularly things like more residents coming to the council for care at a time when funding is going to be challenging. So I think this is definitely an area that, you know, we should all spend time on, and, you know, including me. And another big change that's coming over the coming up over the next year is the transition from the Ccgs to the new ICS. I think that's right, yeah? It is ICS, which is going to be in place on the 1st of July, which is next week. So we're having sort of various discussions about what that's going to mean for us, but really, I guess my observation is that it's going from 8 to 8 units to 1, and we just got to really make sure that our voice is heard, that Kensington and Chelsea residents' voices are heard, that all of our uniqueness, and, you know, I do count Grenfell in that, is accounted for and used in the decision making of that board. And that's going to be a real challenge, I think, for Bernie and the whole department. My priorities are set out, and I'd welcome any discussion around those. I mean, I think the 3 that I'm really focused on are mental health, and I really welcome the work that David's doing with the new strategy. And I think we have to be, you know, all of the work that we've done on Grenfell on mental health, I think should absolutely feed into the work across the borough. We should have those lessons, and also knowing that our residents are all going to be under pressure from the cost of living crisis and coming out of COVID. And I think we're going to find lots of our residents with mental health challenges, you know, perhaps ones that we haven't seen before. So there is a scale to this that I think is alarming and quite concerning. The other piece that I'm really interested in and actually really passionate about is our buildings. So where we keep our vulnerable and needy residents, how we treat them, what their environment is like. And I just think that the environment is so important in having positive outcomes and treating people with dignity and respect. And I've started to visit some of the establishments that we have, and I think each of them have their own challenges, and we have some new ones coming up, Maxilla and Lots Road, and I think actually it's going to be a job for this committee to keep an eye on all of those projects and how they're doing. Are we delivering them quick enough? Are there other areas of the council that we need to push to deliver them quicker? Because this really is where our most vulnerable residents are, and I think it's really, it reflects on us, you know, how we treat them and how we behave with them. So I think this is a really important area. And then for me also is the commissioning, and Gareth probably had in his hand. So I mean, I guess my history with communities is around funding voluntary organisations, and this is a much bigger budget, and some of it's statutory and more difficult to adjust. But I think all of it has to be efficient. All of it has to involve up-to-date conversations with the people that we commission. And we need to make sure we're getting value for money. And I think there's going to be real pressure with those discussions because of inflation. And already some of the conversations that I'm having with some of these service providers about what they pay their staff and how much they have to increase their wages. So, you know, we're probably sitting here thinking, well, we can make it more efficient and take more money out of that. But actually, I think there's really other pressures from everything else that's going on in the world that we're, you know, I'm not sure it's going to be very easy to make things more efficient given, you know, that there's a wage base that's going to be going up. So those are the three areas within my mind that I'm particularly interested in and where I'd really like to make an impact. Bernie, have you got anything to
Just absolutely, Anne, everything you said, just a couple of bits to supplement as well. So there are lots of challenges, as we've identified. There is a very complex area. Our responsibility and our job is to balance all of those, to ensure that all of those are operating at a really good capacity and really good standards at all the same time. And of course, we always do that, and I've done that for many years. The added complexity is exactly as Anne said, with, you know, post-COVID. So you've got some resilience issues. We've got a staff force who did incredibly, I think, through that time and continue to. There wasn't a lull after COVID. We went into other things. So you've got that element that we are making sure we support the staff, making sure they continue to be resilient and we support their well-being. And then, of course, you've got, you know, some of the other challenges that are out there that are mostly in here. You can see how complex, but we've got other regimes that are coming in looking at quality assuring what we do in terms of social care as well. And that's excellent from a resident point of view to make sure their voice will be there. But at the same time, it adds another element of complexity to make sure we are really getting the value for money and it is really, really good outcomes. But there are some opportunities as well, which hopefully this suggests as well, which is, you know, post-COVID, lots of our residents have been doing things differently in a way that has empowered them and given more control to them to actually do what they want to do. And this is a really positive. So we're trying to capture some of that and support that and almost relinquish, without relinquishing accountability, we're relinquishing some of the control to our residents to say, what do you like to do with this? What are the kind of things you want to do? So we've got all of that happening as well. And in fact, if I may just say really quickly, Chair, we just come from an all-staff conference that had lots of residents there and our most vulnerable service users. And I think you could see through the 2 hours we're there, they have a voice. They were there saying the things they think we're doing quite well in. But one of them wrote to me saying, you know, can we look at kind of mental health services as well? So they have a voice and they will determine some of the areas most of the areas we focus on, and they will help us with telling us when we get it right and when we don't. But yeah, lots to do. We welcome it and we're up for it, aren't we, team?
Yeah.
Yes.
It's
all
loads
to
of
respect people.
And actually, on that note about I mean, it is a big budget, but there's a big statutory responsibility. So maybe it would be helpful for the committee to have a small, short paper, not to bring to, but just what our statutory responsibilities are. Because I think you look at the numbers and you think, oh, there's money, but actually, it's high.
Yes, I'd like to say something, Chair. Councillor Siren, she mentioned something very, very important. That the MAG group, where do we go to progress on this project? Because I think it's very, very important.
Maxilla?
Yeah.
Where do we start?
It's one of our priorities as well, which is going to come into the later bit. So maybe might be better to leave it to Max things to add.
Okay, I mean, I think it is important actually to have an update on where we are with Maxilla. I mean, from my point of view, the community piece, I think, has taken longer than we might have hoped. Getting the community steering group together, you know, them Councillor Max, so I think they've been terrific, but it's taken a while, if we're really honest, to get them aligned and comfortable with, I guess, some of the plans, the architect, and we're now moving to the stage of the contractor. So I suppose they still have to do some work. For example, they have to outline a business plan of how the community space within this building is going to work. But in terms of the social care unit, I mean, that's been scoped out for a number of years. I mean, we need to do a refresher on it, but broadly we know what we need for our residents. I guess the bit for me now where I think we all need to push is on the contractor and actually getting the spade in the ground. And that work, I think, is, I mean, the hoardings are up, as everyone keeps telling me, but, you know, we need to get this thing built now.
Yeah.
So I think any enthusiasm encouragement, pressure that this committee can put on our property colleagues, I think would be most helpful. Maybe I'll leave it at that.
Any feedback?
And that's, I 100% agree. And our property colleagues are really trying to move that along. And to be fair to them, what did take quite a while, and I'm really pleased we're in a kind of formally almost kind of concluded place with it now, is agreement on how the space is shared between adult social care and the Maxilla City group. And we've come to what I think is a kind of really helpful accommodation about how to as safely as possible share and blend the space between wider general community use by the Maxilla City group and adult social care, particularly because some of the adult social care services are working with some particularly vulnerable service users and some service users who have behaviours that sometimes challenge us and challenge other people. And so we need to make sure that the safeguarding measures are appropriately in place. But in the middle, if we kind of imagine the way that the bays sit, in the middle is actually a cafe space, which has the opportunity to be the blending point between the kind of more general community use and specific adult social care use. And so we've worked with both Maxilla City and the architects to make sure that the safe but slightly blended distinction there can work in practice. There are some last few design sheets to go through with the architects about the mechanics and engineering of each of the rooms and the occupancy levels. And then, as Councillor Siren says, it's about getting the development contracts finalised. They're already on board, but actually get them moving with quantity surveyors, etc., so that space can start being floor.
Thank you. I just think that we need to step on it, because if that building might take another 3-4 years to be built, if this is a transformation process, things need to be in place in order for community care. If we can identify, which we know that a lot of local residents are in need of mental health services and adult social care services provisions. So I think we need to do something about that very soon.
Anybody else? We're going to ask you a bit about the strategies that you're looking at, which is the mental health strategy, the substance misuse, and suicide prevention. On sort of where you're at with the development of these strategies and the timelines.
Maybe hand over to David to talk about mental health first.
Yeah, sure. Thanks for the question. So at the moment, we're currently engaging in some community engagement forums. So we're bringing together people from the community to give us an update, just to give us an idea of what they would like to see in the mental health strategy, how they want the services to kind of adapt to meet their needs. And so, in fact, for the last 6 months, we've had a series of kind of engagement workshops. So we had a market store at Portobello Road, where we had a real very good turnout of people approaching us. Initially, I thought people will not understand some of the mental health services that we have in the borough, but I was actually wrong, because some of the people that actually came were well informed, because some of them have had engagement in terms of the family kind of situations, or even some of the services themselves, or they know neighbors who have had mental health services. So we got very good information from that forum. We've also had tried to get a number of professionals together, stakeholders, professional organizations like the ambulance service, the police, the CCGs, and CNWL, together just to have a discussion around understanding where the gaps are within service provisions. And just to add on to the point that was mentioned earlier, we've kind of developed a new group of commissioners to look at in service mapping, as what Bernie mentioned earlier. So we are grouping together what exactly is the CCG funding, the CNWL kind of monitoring, and also self-assault as commissioners. Where exactly are we funding to understand the kind of the whole kind of landscape in the borough. Additionally, we know that there are some new services that have come up that have not been, they're not receiving any kind of funding from any of the main commissioners like the CCG or the councils, that we need to also include in our community engagement, because they also provide some services to local people where mental health is an issue. So in terms of the process of the mental health strategy, we're looking at towards the end of the year, so around October, November-ish, for concluding that. We'll definitely be doing a consultation as well with our local people, so that they're able to kind of express their views around the draft paper as well. Yeah.
So I think our next meeting is October, because I think we would have quite liked to have looked at the strategy before you.
Yeah, absolutely.
I guess you could circulate it to us.
It was certainly a large element of it. Of the
Yeah,
draft.
sure, of course. Yeah, of course.
But October would be too late for us to really have any input.
Well, I think David's very carefully saying it maybe towards the end of the year, so you may well be able to have an October.
It's just when we're planning our work.
Yes, yes. So I think that might, in fact, that would work if it was October, and then I think you're talking November, December. That would kind of work perfectly.
Okay.
Sure, thank you. The gentleman said that he was engaging with some community forums. Can you send me a list of who they are, please? And then if anything, I'll send you some more that you can related to do with drug rehabilitation.
Thank you. Thanks.
It's actually one of the things that came up in our North Kensington review was the access to the spa.
Yeah.
And that's actually something we'll go to visits later, but that's something we were going to do as well.
Yeah.
Thank you. And then the substance misuse strategy.
So the substance misuse strategy that we're working on is predominantly a strategy around children, young people and their families, and it's linked into serious youth violence. So we commissioned that strategy from an external organisation. We've just completed a draft of that strategy now, which we're about to take around various committees for their comments and their feedback on. So it was going to go via a children and young people's route, but there is no reason why it couldn't also be shared with this group for information as well, or for discussion.
I mean, we could do a joint, we did before actually, a joint. I think that would make sense.
Yeah,
actually.
So that would be a good option for that. And in terms of the suicide prevention strategy, that piece of work has been completed. So that is available as well, should you wish me to circulate it to this group.
I do have one question, which we were talking about improving digital with Westminster, which is something maybe a question for Bernie or Councillor Syra. You mentioned 9.1 and your priorities about improving the digital offer. Just wondering if you could give some more colour to where you think the authority might be falling down in its digital approach, and what we might be able to do better, and then subsequently how that may have, whether or not it will, but may have any impact on cost savings or efficiencies. You could get some colour to that.
If I want from this is a very important but quite specific question.
So I'll give a bit of an overview, if I may, Councillor, and Gareth may come in here has much more of the detail of the plan we're doing. So previous sort of committees or scrutinies will know that we talked quite a bit about empowering our residents through digital technology and acknowledging that it will not be for everyone, in the same way as our health colleague said, you can't just go down this route. But I have to say, we do know, because we have a good voice of our residents, that they would like to use a lot more of services through digital. So they would like to look at what are the kind of services that they could purchase for themselves if they had a direct payment or something like that, rather than the power coming from us telling them these are the options you've got. So they've already expressed for many years that they would actually like us to develop something like that, where they could look at the services and they could kind of commission it with us, of course, supported it. And of course, one of the things I was alluding to when I spoke about COVID and the opportunities is many more of our residents were using technology through that time. We had, you'll know from our care homes, we gave out hundreds of iPads and people were using that to contact relatives and things. So actually the awareness and the understanding and the usage of technology has really enhanced. And that's one of the things we were talking about. They said, now, okay, you started this, we would like to see more of it. So we are already developing kind of a wallet, so to speak, and a platform where people can go on and see all the variety of services. And then also we are trying something that will have a payment for it. So rather than saying this is what we want, and then you have to come back through a more traditional approach in a council where you give invoices and you go through that, they could actually purchase it, as many of us would do for some services we want. So there are lots of bits that we're doing on the wider, and it's a really good question in terms of the strategy, because if we were to empower people to find more for themselves in terms of the care, actually the feedback from some places that have used it is it's better outcomes, people feel more empowered, and actually it's much more efficient. So you can get rid of some of back office where you're going through all the invoicing because people are able to do it electronically. And of course then with that, with lots of the checks and measures, I have to say, so I know people get concerned, you can empower family members to support that as well rather than just individuals. It works really well. But we do also have, when we talk about digital, we talk about tech we use as well to support people. I don't know, Gareth, if you want to do a little more on the tech.
Yeah, thanks, Bonnie. I think for our programme, I tend to think of it in kind of three specific areas. One is the tech, as Bonnie said. The other is, the middle one is platforms, which Bonnie's talked about in terms of the sort of digital wallet or account that people can use. And the third bit is tech for staff to make things more efficient. So on the tech bit for residents, what we've been doing across the Borough for a few months now is running some effectively like Dragon's Den events, because we get approached all the time by what's a really thriving market for assistive technology, digital technology in care and health, by organisations saying, could we work with you and some residents in the borough to try out how this works. So we tried to find a way to manage that and police it a bit through running a series of events where we've done them in the Great Hall and the Small Hall here and some other venues, where we have some local residents and service users, professionals of social workers and occupational therapists, and kind of commissioners and other partners in the room watching some pictures from these organisations, posting them some questions, and then at the end of it, we might identify kind of a top 3 out of the 10 to 12 that we've spoken to and look at the potential to run some pilots with them. So we've got a few of those up and running now, but it's a process we've been using to try and onboard and test out the way that market's developing, if it's something that our residents and service users and professionals think has legs, or is something that we haven't tried before. Because you get a lot of things like sensors in the home or GPS devices that people could wear, where there are umpteen of those organisations, so you wouldn't really want to try out all of them. And there are other organisations that are doing that trying for us, a bit like a kind of a Go Compare version of assistive technology, but we're trying to do it where we're picking out new and different things that people have expressed an interest in, and where we can bring them on board.
I think that is a very good system because it will provide customer satisfaction. So, for example, you're in a GP surgery and I want to give them my information. I can just type it in instead of saying out aloud or put it on a piece of paper. It's privacy as well, you know. So I think that is a way to go forward. I just think we need to equip our local residents and to make them aware of these services and to encourage them to use it more often.
It is what they use in the dedicated service, actually.
I think it's a good system, but we need to.
And some people don't want it, but more and more people do.
Yeah, I'll prefer to not shout my name across somewhere. I would prefer to type it. Or personal questions, I'd like to just type it because it's just going somewhere to get analysed and not someone's desk.
Thank you very much. I thought this was a really good paper. It gave everybody a really good introduction about what you do. And yeah, no, very good. And if we could just have something on statutory responsibilities, because I think that would be quite helpful. Great. Thank you very much. I think it's changed our work programme. James, would you like to introduce the next report?
Thank you, Chair. So the next report is essentially an output of the programming workshop which we held with select members and other non-executive members on 9th of June. As members will be aware, the committee has a very broad span of responsibilities across public health, adult social care and health. So we do recommend that you do prioritise key themes, the key inquiries you want to look at in any municipal year. So the essence of the paper is set out in Appendix 1, which the members set out those main 6 areas which they would like to review in the forthcoming year. In addition to that, the paper also notes as well that the committee would like to look at the annual adult safeguarding report again this year as an important item. And also notes, we've already discussed this evening, the ongoing changes around NHS structures which will form the backdrop of the committee's work this year. So essentially, the paper asks the committee to confirm that these are the main priority areas, subject to any changes members may wish to make tonight.
We're going to have to make some changes. If we do if the substance misuse has already been written.
Suicide.
Oh, sorry, suicide.
Yes, so the suicide prevention strategy is completed.
Okay.
And we've got a draft for comments on the children's and young people's substance misuse strategy.
So maybe, could that be sent to us as well? So mental health we're going to have to do in October now. Looking at the other ones on our list, is there anything timing-wise would make sense? I think we're going to have to do palliative care in October as well. Day centre opportunities. That was really to take in St Mark's Road, Maxilla, Pepperpot, Chamberlain House, and any other day centres. When would be a good time for us to look at that?
I mean, so thank you, Jay. It is that, it is all absolutely as you say, but it is also, it could be, it's absolutely up to you, even wider than that. What are the opportunities for vulnerable people in Kings and Chelsea? So we like to think of them in place space, and that they may often have to be, but it is wider than that. How can we look at it all? So we haven't started that, but I think it's a piece of work that we really should be doing. So that, and we'll need to do lots of engagement with this, because I know the residents have a very strong view on what things they would like out there, and we may need to think very differently. So I think that may take a little longer, but I think it will. But at the same time, some of the elements within there are really quite critical. You know, the Maxilla, the Chamberlain. So unless we do it in 2 parts, which I know we've done before, where we load the bits that are absolutely essential, and then we learn a bit from that, and we do a wider strategy on the back of that. It's up to you.
I'm just thinking if there are some places I think it would be good for the committee to go and visit if they can. Which would help. Yeah. So do you think November would work if it came? We had something in November.
Making to all of you in a rush.
I mean, I know Maxilla needs the pedal.
Yeah.
But maybe
I think November as a kind of a, it won't be a full strategy, but there will certainly be a scope, and this is what's out there, this is what we think the direction of travel, this is what the residents we've spoken to would like. We know this from a whole range of activities. I think November should be okay. Yeah, I'm getting nods, that's good.
Yeah. Okay. Obesity. We had how many years ago? Go Gulp. Yeah. Then it was taken into Change for Life, which was about to be commissioned, and then I think COVID stalled it. Or I can't remember, it just went out. Anyway.
Change for Life is alive and well and in operation across the borough at the moment. A lot of the learning from Go Goulburn has been adapted into that model. We've done some work on a whole council approach to obesity, and there's a particular focus at the moment on Chelsea Riverside, and Bernie indeed chaired a launch event to our whole council approach to obesity recently in partnership with Sue, our Director of Communities. So that's certainly something that we could talk to you about relatively soon in terms of the overall approach. In terms of outcomes from that approach, that will be a little bit further down the line. But it's a really exciting piece of work and leading the way in terms of obesity being an ICS priority.
Another number ones are the ICS, the local space.
Right, because I guess diabetes and everything.
Yeah, we have very high numbers.
So yeah, it was just whether we did anything with children's on that and then keep going all the way through, but they didn't seem to be particularly interested, so maybe we just do it at this committee. So when would be a good time for that, do you think?
Are we gonna focus on the prevention or the secondary care of obesity? What
Everything should be all encompassing. Yeah, yeah. I mean, that's more developed than some of the other things we've talked about, isn't it?
So November or
it's gonna be a good month, November. I mean, we can certainly by November. Yeah. There's a lot, yeah.
so we've got day centre opportunities and obesity, is that?
Well, obesity, I mean, I don't want you to, but if you said in another month, we'd probably have that together. That's very well developed. So I'm not worried about that for November. The day centre one is more of a kind of scoping and those bits that we know that we absolutely have to do. And what was the other one? So those two I'm not worried about. And then
The
substance
substance
is
abuse
fine.
so that's taken that off.
Yeah.
And I think we've got to have something on the ICS, but I'm not sure when, because I think now is too early.
Well,
Or maybe it's always
September, October, November. That'll be 5 months by then. It will be probably after 6 months after the 1st of July. That's really the soonest you could probably look at it.
We've got October, November now. When's our next meeting? February. Is that too late?
These what decisions are made in those 6 months. Yeah, I think it probably would be. We would absolutely alert if there are some big changes, which I think is unlikely, but if there are, we would.
Should we say February, and then if we have to bring it forward,
Yeah.
We can move things around. Does anybody else have any other comments?
Palliative of care. I mean, they're moving fairly fast.
Yes, we put that in for October because that's some.
Okay,
Yeah.
good.
Anything else? I mean, I think things will come up and we'll, but this was just to give it some items for the next few months. Anybody, no other comments? Portia? We go to any other oral written items. I think the first thing is visits. I forgot to mention in the mental health working group recommendations that we were going to discuss far. I think it would be really good if we could do some other visits. Obviously, Chel Wester said we can go and visit them. I think going to see some of the day centres would be another good one. I'm not sure what the feeling is for care homes at the moment as COVID is rising again.
Yeah, I mean, if it carries on the rate, that I imagine they'll get a bit more anxious again in the next few months. On that.
So we'll take your advice on that, I
Yeah.
think.
We have an interim view visit to Ellesmere that has been completed.
Right.
The report isn't ready yet, but it will be within a month or so. I think.
Great.
Is there anywhere else that you'd like to visit?
Cautious.
I'll send you the list of.
Do.
There was a look at as a literary plan, actually completely outside of our but someone told me about the other day, which was very useful in terms of
We should go to the Grenfell Health and
It's
Wellbeing.
actually Felicity talking about it. She said we should go to stuff.
Actually, CNWL, when we were there the other day, said that. But I'm going to the spa. you go and stand outside Maxilla.
Done a lot of that.
Shout. And then finally, I'd just like to say thank you to Christine. This is her last meeting. And I think everybody has known Christine for quite some time, and she's brought so much to this committee, bringing their reports and their issues, and sort of really fighting for our residents. So thank you, Christine, for everything you've done. We're going to miss you.
Thank you. That's very kind. Thank you all. I've enjoyed working with you, and I do wish you all well. But gracias and everything else. I look forward to following you.
So thank you, Christine. We really will miss you. So I think that's it for this evening. I think the next meeting is on Thursday, the 20th of October. And thank you everyone for coming this evening.
Thank you.